I'm still letting in some people here. But while some folks are trickling in, who wants to go first in terms of sharing some reflections about the reading? What stood out to you? Hi, Brett.
Well, man, if I can say something straight away,
Go. Shoot.
it's such a intriguing, wonderful, and somewhat deep journey into this ISTDP. But every time I read something, especially these two articles again, there is a sense of overwhelm. There's a sense of every page or two that you read.
Mhm.
There's some sort of new thing you've got to consider when you're sitting in front of a patient or a client.
Mhm.
And then you're thinking to yourself, in any given 5 minutes, I've got to have like 20 things in my head, you know? So I just noticed that again with the readings,
Yeah,
Now, so, yeah, and don't forget, you've got to look at this, and
yeah,
this.
yeah.
So, yes, that's a new thing I've never seen. And then the second thing that I'm becoming more acutely aware of, and it reflects on one of the guys last week said, is there a book? And then you recommended this book,
Yes.
is that there's a depth of knowledge that clearly Davanloo had that he could bring to bear, that he just enriched whatever's going on between him and the patient. And some of us are just not psychoanalytically trained
Mhm.
or classically trained or whatever you want to call it. I just don't have that knowledge.
Mhm.
So I just so happen to know about the Oedipal complex. But
Mhm.
I can tell you that nowhere in my studies at university was I introduced to that concept.
Yeah.
So it's just my own personal reading that I've come across that, you know what I mean? So, I feel in that way also not, what's the word I'm looking for? Not incomplete, but
Mm-hmm.
not up to the task, if you will.
Mhm.
Because it seems to be, it seems like you need to know that stuff.
Mhm. Mhm. No, I understand why that would be intimidating, and overwhelming. Totally. I think Max said the same in our last meeting. And so I get that. So there's something to be said for trying to bone up and do some reading. But having said that, though, my bias is that once you do all that reading, forget about it and be really present with the patient and trust that that will come to bear as needed.
Yeah.
You say that as though that's an easy thing. That can take a decade or more.
Fair enough.
You
That's
want
it.
to sit down.
Yeah.
And
Yeah.
I was what was the year of this book?
Well, I think it's 1977 or 78.
Oh, really?
Hmm.
I knew that Davanloo knew Freud very well and followed in his footsteps, but I didn't know he was such an psychoanalytic scholar and a genius psychoanalyst. I didn't know that about him. It's and I also wondered, in terms of the Oedipal complex, we don't deal with that in ISTDP. I've never heard anybody talk about it before. And I'm wondering if it is something that, well, Davenport was already well into his work when he wrote this, but it's I think we deal with pre-Oedipal issues, not Oedipal issues. And it seems like everything I've learned in ISTDP is appropriate for pre-Oedipal people. What do you
Uh,
think?
yeah, I don't know about that. I mean, pre-Oedipal tends to be associated with fragility. So if you're referring to like the graded approach, then I would agree with you. I think what we're looking at is that in the standard ISTDP, whether it's pre-Oedipal or Oedipal, it's dealt with post-unlocking. So I think the idea is that if you get too much in the weeds of that and you try to understand the content of those kinds of things before there's an unlocking, you could be colluding with resistance and defensive intellectualizing. So
Oh,
there's this bias that let's just get to the unlocking of the unconscious, and then we can sort out, what are these Oedipal conflicts or pre-Oedipal conflicts that we're dealing with. So that's my understanding, but I'm open to different perspectives here. Yair, I know you have thoughts about this.
Yeah, I when I read this article, what came to mind is I wonder what would Davanloo, if he was alive and we sit with us, what would Davanloo say today, think about today, about his work back
Right.
then?
Right.
Um, because in a way, I sense that as what struck me was the way Davanloo he is unrelentless with being curious, trying to get to know the patient, trying to um, convey the patient, be with me, look at this with me, be interested in what is going on, think about what I'm saying to you, check it in. But the way he does it is he listens, he offers an interpretation and then he invites the patient to look at the to examine the interpretation. And his later work is to go to the is to point make the patient listen to his experience, be in touch with his experience, and then when once the experience and the UTA brings the person brings things, and there is like an emotional experience, then there is an interpretation that comes in a way and trying to arrange those things. So
Yes.
it was very different,
That's true. Although, I'm thinking about the case of the angry childlike woman. No, no, is that no, the Dutch little blonde girl. That's the one we read, right? Not the
right?
yeah. Um, in that transcript, there was a little bit more of a focus on how do you actually experience that right now? So there was that focus. I remember that. So I think there was more of a blending of both cognitive interpretations and exploration, but also some focus on the here and now experience.
Yeah.
Good. Thanks for that, Yair. Anne, go right ahead.
Yeah, his timing,
Mhm.
his way of understanding the unconscious and what makes a person tick
Mhm.
is shocking. At
Mhm.
every turn, he's doing something that is brilliant.
Mhm.
And especially when he stays with the affair that the guy's having instead of trying to get into generic material, which it reminded me of why we use dolls in play therapy because it allows a distance. And Davanloo knew there'd be repetition compulsion. And he allowed them the distance of the dolls, like playing with the affair, rather than dealing with the genetic material until it came down until he put the whole thing together from the affair back to the genetic material. It was just,
Mhm.
I mean, there was a certain joy, of course, terrible envy, but a certain joy of reading something so brilliant,
Mhm.
so extraordinarily brilliant.
I agree. I have the same experience. There's some kind of beauty about it that's hard to put.
Yes,
Yeah.
that's it.
Yeah.
Yeah,
Beauty.
yeah.
Yep, yep. I saw that when I saw his work. I was in Montreal for a couple of years, and there was this seamless quality to his work. And he was laser focused.
Oh, yeah, absolutely.
Mm. Good, good. Anything else? Who wants to share next? Brett.
Um, I'm hoping I'm not alone in this. I largely had a negative reaction to the cement mix man. Not in that, I thought it was awful. There was some of what Bert was saying and that I felt uh, kind of not incompetent, but it felt like it was very much same with the second chapter as well about evaluation. But it very much felt like I was like, oh, I've been doing this for a little while now, and I don't know very much. Like
Mm.
that was kind of like thoughts I had. It's like, oh, okay, I've got a lot to learn still. But then I could take some time to reflect and look at it and think, okay, he's putting into different terms that I hadn't really had used as frequently as often, but the concepts are similar and I can put it together. So it was good. But with the cement mixer man specifically, it was I felt like if I had seen only this version of ISTP, I probably wouldn't have gotten into it because I really found the constant interpretation kind of
Mm.
challenging, I suppose. I think there was one specific passage as well that felt a little bit forced to me, and I'm sure it probably looked better on the video, but in transcript it felt a little bit forced with the 364. I think it was the start of the 10th session where he's looking at being late.
Mhm.
I felt like I kind of got why the patient was was kind of fighting back against it. It was like, well, this is really different from my wife. This is, this is the first time I've been late. Like, I was like, yeah, I wouldn't have focused on that. So I found that really interesting.
That was interesting. That was one of the passages that stood out to me. If I'm remembering this correctly, what happened was that the patient pushed back, and then Davanloo eventually relented. The patient said, well, actually, this is not a good example. Then he said, this would be a better angle. This would be a better point of entry in terms of our relationship. And then I can't remember what it was, but he brought up something that was irritating to him about Davanloo, or should be, but that he wasn't feeling it, or something to that effect. That was a pretty interesting passage. But thanks for sharing that, Brett. Yeah, more of a negative response. Good.
Yeah,
I'm hearing a voice, but I'm also seeing a
yeah,
hand.
it's mine. Sorry,
Okay.
Jonas, I don't want to hog it. Yeah, I'm just following up with what Brett said, that you've been doing it for a while and you read something like that and you feel like you don't know anything. I'm sort of getting to this point. I don't want to personalize it too much, but I'm getting to this point where it's saying, now, do I take my time and go and travel around the world and see interesting places? Or do I become a monk for ISTDP? Because it feels like you almost got to become a monk, and that's all that you do. You just do ISTDP all the time, reading, studying,
Right.
reflecting, looking, watching videos, again, book clubs, it just goes on and on and on and on.
Yeah.
And you're never competent,
Yeah.
or
Well,
even a modicum of competence,
hmm.
because it's almost like if you're not Davanloo, you don't know what you're doing.
Well, if I may, though, Burr, I've seen your work, and sometimes your work is absolutely brilliant. So I would push back on that idea that you're so incompetent. I just disagree. I've seen your work, and sometimes you're incredible at what you do. So I don't know about that. I do question what you're saying there. But in terms of like going overboard with therapy, and making that your whole life, and you do nothing but think about ISTDP, and you can't have a conversation with someone without talking about therapy. Yeah, that can be too much. That can be a sign that you need some more therapy, actually. If your whole life is one big therapy session, it means something is out of alignment.
Can
That's
you help me on this? Can I come to you for therapy?
uh, so I think Stephen and then Max.
Okay, sorry, I'll try to be brief. I just wanted to follow up on what Brett said because I'm wondering if, when the therapist pointed out to the client, for example, how come you're not irritated or annoyed at me for showing up late? And he says, oh, well, I know how difficult it is to get here on time, Montreal traffic, blah, 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 et cetera, et cetera. Yes, but still, one can still plan in advance if you know that there is the fact that you're going to have to deal with the Montreal traffic, right? And so I think is that what I would say is that a defense against avoidance about not wanting to express his irritation about the fact that the damn therapist is late
Yeah.
because I don't want to. Okay, I'm going to be a little bit vulgar here, but not as vulgar as I have been. I don't want to upset daddy because if I upset daddy, I will be distanced from his love, which is what I see as being the story in some ways of what's happened with this particular situation, with this particular client, right?
Mm. Love that. Love that. I agree.
Sorry.
No, I agree with you. That was great, Stephen. Thank you. No, that's right. I mean, that was clearly Davanloo's angle. And maybe if he had said what you're saying, maybe that would have penetrated. But part of what I appreciated about the passage is, again, that Davanloo, he tried something and then he realized the anger was just too inaccessible through that point of entry. And then the patient course corrected to say, hey, let's look over here. So I thought that was pretty cool. Max, how about you?
Yeah, thank you for all the points so far. So I want to make a couple. I don't think there was like there wasn't really a breakthrough in this case to feeling, or there certainly wasn't an unlocking and correct. And so I get the sense, I don't know when all the papers were written, but I get the sense like he's not doing ISTDP yet. And
I
this is a
agree.
yeah, this is a bunch of psychoanalysts sitting around trying to do short-term psychoanalysis. They
Mm-hmm.
haven't He hasn't broken off yet, and he hasn't done the central dynamic sequence yet, and he's not looking for unlockings, and he hasn't figured that piece out. And so that's one thing I wanted to say. And it's a harder one to read because it's so Freudian. It's the focus on the breasts and the sex and some guy, one of the other analysts at the end talking about pseudo homosexuality and stuff like that. It's so Freudian. It's a kind of in some ways how we've now it's like comical in some ways to be so focused on the sex and mummy and daddy and stuff. And not to say there's no truth to it, but it's a very kind of old school case. And I do have other things I want to say about the other paper, but I'll wait until we're done. But I did want to speak to Bert, and I saw Yair in supervision on Friday, and I was just thinking, it's like you put in hours and hours, and you get an inch, and like the next session you do an intervention better, or a new intervention, and then you go back and read and do supervision hours, and then you get an inch. But that's the way it is. That's the way it is with everything. It was the same thing. Like, I'm just speaking generally. Like, it's as an actor, it was hours and hours and hours of trying something out, and you get to do one thing different or better. It's hours of work, and you get an inch. But if you just keep going, and eventually, yeah, you do get really competent. You get competent. Like, I believe I'm competent, and hopefully over time, you get mastery, right? I just wanted to share that because I know it's something we all struggle with.
Yes, it is. Thank you for that. Thank you. And just a minute, we have with Harrison, and then you can go in. But I just wanted to say that no, that's a point well made, Max. I do think that a lot of what we see in ISTDP is baked in here. So I'm not sure that it's a difference of category as opposed to degree. To me, I get the sense there's a difference in degree, but not necessarily category. We see confrontation, we see clarification of defense and resistance, we see efforts to get underneath all of that. To me, that is very, very integral to what ISTDP is. But in terms of like a vertical approach, definitely not. We don't have that here, which is why I guess it's called short-term or broad short-term dynamic psychotherapy. So point well made, point well taken. Um, Harrison.
Yeah, I just wanted to kind of follow up with a lot of the themes that we're bringing up. I, you know, I know, Patricia Coughlin's done a lot of work with kind of more the sexuality components of ISCDP, and but I agree when we talk about the Oedipal complex this way, and the patient did buy into it at the end. He was talking about confessing and recognition of his sexual feelings for his mother, but um, yeah, I always have struggles with that, and I'm sure Freudian analysts would say I need more analysis then. But even with different supervisors who were analysts, some of them say it's all just a metaphor. It's not all about sex, and some others are more hardcore Freudian that way. But um, to piggyback off of is this ISTDP? I'm looking at kind of the evaluation criteria article, but since they were all written around the same time, I mean, there are some things that they said. So there's one section where it says the evaluator should take into consideration that in the first interview, some patients show inhibitions in the communication of their inner emotional experiences. And by the second or third interview, resolve these inhibitions. There's almost this recognition that, yeah, people are gonna have resistance against emotional closeness on the first session. They don't know you. And I think that's a very real thing that in later Davanloo, I mean, it's just kind of hammered away from the get-go. From first session, we're not going to tolerate that and target that and view that as transference resistance. So I struggle, what's the right approach here? Because on one hand, it makes sense that people need to get to know you with time, but at the same time, there's this value system we have in ISTDP that we want to get to results as quick as possible for their own sake. So that's kind of like a dialectical tension I struggle with.
Yeah, good point. Although referencing Coughlin again, she talks about how slower in the beginning can be faster in the end. You take a little time, get to know the person, develop that kind of a rapport, and establish yourself as someone that they would actually want to open up to. I tend to lean that way as opposed to going right out of the gate with heavy pressure, because at that point they actually have a reasonable reason to not open it. Like, hey, I don't know you. You know nothing about me. Why would I? Right. And so to take that off the table by first establishing yourself as someone they'd want to open up to. I do agree. Anne and then Sophie.
Okay. Well, I think he did take the time in the beginning to and also remember how absolutely successful his work was going straight into the Oedipal conflict and staying there. The end of the work was really stunning. And I want to say, I just wanted to share this. It's something that gives me great peace about not knowing what I'm doing. And that is, there's a Colburn School of Music here in Los Angeles. And the one of the professors there, when he starts on a Beethoven symphony with new people, he said, and now we're going to walk into the mind of a genius. And I just feel I feel, yes, okay, I'm walking into the mind of a genius. The way this man put things together and his timing and everything is absolutely elegant. And if you understand psychoanalytic work more, you even like Judd Marmer and these men who were giving the discussion were blown away by, and rightfully so, because this is a master of psychoanalytic technique. And I did see the precursors of challenge, pressure, the wall, crystallization, even the head-on collision. There was just a little something. So we have we're looking at something that is beyond us and that we strive for. Anyway,
I have a similar experience, and I agree. The contours of what you find in ISTDP, they're there. They're there. Sophie.
Yeah, just to follow up a bit about what we discussed earlier about how Davanloo you can like that he sometimes feels a bit almost forceful, like in the transcript of the cement mixing man. I really liked, I don't remember the page number, but at the end of the article, at some point, like Davanloo and the audience are having a discussion about him being or appearing like coercive, persuasive, and pounding on the patient.
Yep.
And I like the comments that they make because what I wrote it here. I don't remember if it's Davanloo or someone else who says, well, what do we mean when we say that he appears coercive? And it's essentially the idea to force the patient in thinking about the problem and not letting go of it. And quote, while not being directive, but instead insisting the patient comes up with the answers himself. And quote, to have the patient do the unfolding. And I really liked that way of describing it. And you can also see later that when the patient's own reactions and evaluation after the treatment is being discussed, the patient himself will like comment that he felt that he had done the work himself. It wasn't like you, the therapist. The patient says, I listened to you, but it was I who decided to learn how to live with myself. And so I thought that's like an interesting perspective of how the patient apparently seems to have felt that in the therapy.
Totally. Yeah, I thought that was so cool that the patient would come back and watch video of the therapy and then comment on it. And yeah, from what I can tell, it was clearly very, very successful that he turned a corner on a lot of his problems, including the compliance. He was quite compliant with Davanloo at the beginning, apparently. So he turned a lot of corners. I think it's Bert, you're up.
Yeah, sorry, it's me again. Just again, a few comments. They're going slow in the beginning and fast later on. I really get that, and I really appreciate that. I mean, that's generally more the way that I work anyway. But again, in terms of learning ISTDP and becoming expert and going more than an inch, as Max says, I find that in supervision, if you're going slow in the beginning and you show one of those videos, There's almost like that thing of, yeah, but do this, do that, do that. And you're trying to say to the person, listen, I'm going slow in the beginning.
Mm.
And it's almost like that's ignored and just said, yeah, but you've still got to do this and do this and do this.
Mhm.
You know, so that's just one thing I want to say about that. And then the other thing about, we get an inch is
Mm.
that I found with other therapies, and I might not be comparing apples with apples,
Mhm.
but like acceptance and commitment therapy.
Mhm.
When you learn acceptance and commitment therapy, the next day you've gone 1 meter.
Mm.
Understand? Because it's very clear what the structure is
Right,
and what you're focusing on.
right.
And you can feel it. I'm going through the hexagon. I'm getting there.
Mhm.
So I feel that's sometimes my frustration.
Yeah. Yeah. Well, that's
Yeah.
valid. It's understandable. I think that it often takes a good 5, 10 years to really be competent with ISTDP. It's very complicated. Good. Let's see. Britton, I see a thought bubble there, but no pressure if you'd rather not speak up.
But I think that's why probably most of us do this, though, right? If it obviously I'm inserting myself, my experience, but just the general sense that there is complexity here is really almost comforting. That there, because we all kind of have a sense that there's so much more to us than just what would be in the hexaflex of act, right? And there's something about this process that really makes you feel that and like, oh, okay, this can feel real. This can feel like there's something there. It's so much more than just, yeah, I'll have this in a weekend. I'll have this in one workshop. That's great, done. When I go away from every workshop, going, okay, yep, still got to learn everything again. But it's a positive too.
Yeah, and I absolutely agree with you, Brett. I mean, I wouldn't be doing it otherwise. I'm on the same page as you there. It's just that, there is that sense of, and maybe it's too much of the accountant in me, but it's like the return on investment, both time and money. You understand that you're saying I can do act and, one weekend workshop, as you say, Brett, and then I can make the same money and go on holiday whenever I want to, but now I've got to spend time with the ISTDP,
Right.
so what's the return on investment here, you know?
Right.
So it's that sort of thing that also comes in. But I really appreciate what you're saying, that there's a depth to it and that there's more to us than the hexaflex.
Yeah. And it's also perfectly normal to have a bit of a love-hate relationship to the process of learning ISTDP. I think a lot of us feel that and go through that. So I totally get it. Good. Um, let's see.
I'll shut up.
No, you're good. Thanks, Bert.
Oh,
Thanks.
you're good.
Yeah, exactly that. Did I miss someone? I missed someone.
If I may,
Yes.
I wanted to kind of bring up a section. It's
Hmm.
in the Mixer Man article, but towards the end, there's a section on 379 where Davanloo talks about how, some people, and especially in this guy, intellectual insight has to come first, and then the emotional insight comes later. And he talks about how the patient really didn't emotionally understand what he was talking about in terms of anger towards him, but then he had this experience at a family barbecue where like he had a eureka moment where it's like, oh, I get it now. And that seemed oh the in ISTDP proper, quote unquote, whatever
Mhm.
I mean by
Mhm.
that. It feels to me that oftentimes kind of the emotional experience is aimed at to arrive first, and then you can kind of do recaps with intellectual understanding.
Yeah.
Um,
Yep.
and there isn't as much room for this kind of work where he still seems to be very much valuing intellectual insights and saying that's not, you
Mhm.
know, out of order, so to speak.
That's good.
I thought that flexibility was, I appreciated that.
Yeah. Yeah. Yeah, he seems to be saying that, in fact, the intellectual insight lays the groundwork for emotional insight, and then later the integration between the two. That was my impression. Was that how you saw it too, Harrison?
Yep, that's exactly how I understood it.
Yeah.
But yeah, and this might purely be my personal bias, but I haven't heard that in my own training so far, where that's equally as valued. It's kind of more
Mhm.
focused on emotional experiencing.
Mhm.
Um, that's more valued, I suppose.
Yeah, I agree. It's been my experience too. Anne.
Yeah. Well, I wonder in terms of what you were just saying, Harrison, I wonder when Davanloo flipped from laying the incredible intellectual cognitive groundwork that he laid in this session when he was definitely working psychoanalytically. And he then said, no, let's work here emotionally and somatically first, and then bring on, and so on. So I was really taken by surprise by this article because I didn't realize I hadn't read anything of Davanloo being a psychoanalyst. I'd only read of him doing ISTDP, so I don't know when that flip came. This was only in 77 and 78. So he'd been doing it for 20, he'd been working for 20 years.
Mhm.
60s, early 60s. So but Harrison, um I don't see him doing any kind of the what you were referring to, the somatic and the emotional work. He's strictly interpreting. Yeah.
And confront. He's also
And right, he begins with challenge. He does challenge and pressure, and in these little snippets, more
yes.
toward the end than in the beginning. But even so, I think I thought I was reading. Oh, this is the precursor to that, and this is the precursor to this other thing.
Right. That's right. No, I don't know for sure, but my sense is that something happened in the 1990s because
Hmm.
the chapter he wrote in a book called Frontiers of Dynamic Psychotherapy, or I think that's what it's called. Don't quote me on that. But
Hmm.
there's a chapter called The Unconscious Therapeutic Alliance in that
Yeah.
book. And that was published, I think it was in 1987 or 86, something like that. And in that chapter, he writes about how interpretation is one tool of many to chip away at resistance. So in the late 80s, he seemed to believe that it could be helpful for some patients. Whereas the stuff that I've read from the 1990s and onward, he takes a different tact.
Yeah. Are you talking about that UTA chapter in Burke's
Yeah. What's the title of that book? Can you read it?
Frontiers of Dynamic Psychotherapy, Essays in Honor of
Yes,
Louis
that's the one.
Wolfe,
That's the one.
and it was written in 87.
Yeah, 87. Yeah, so I had it right. The title was right. Yes, that's the one. It's a great, maybe I'll assign that for a reading coming up now. Um, Yair.
Yeah, I mean, following those last comments, um, also regarding competence and regarding Davanou's work, um, I would think about the phrase that David Malan would say. That it said that like Freud discovered the unconscious, but Davanloo discovered how to work with it
Yep.
therapeutically. So,
Yep.
and I think that like what we see in those earlier in those earlier papers, when we see Davanloo work like more psychoanalytically, like at that for that time it was mind blowing because it was something new also for psychoanalysts. They saw something an active therapist who was really is working in this way, and it was new. It was actually effective, and for that those time it was highly effective and was really mind blowing. I think, but he doesn't like if we talk about the way he Davanloo like follows the unconscious, we still don't see it the way he does it later in the 90s, where he's paying much more attention to nonverbals, to nonverbals cues as signs of the unconscious. And I think that that phase when he started to put more emphasis on that's it. I assume that maybe that's what Malan was referring to when he said he discovers how to work with with the unconscious.
Mhm.
Because right now we see a lot of work on the analyst side of using the psychoanalytic knowledge to offer interpretation and then like challenge the patient from what he says, what he says and what he refers, but not how he acts or what his body language tells us,
Mhm.
which he does later. And I'm thinking about also about competence
Mhm.
is when Davanloo says, like in this paper, sometimes the patient has an intellectual understanding first and then the emotional. I mean, for him, he is still, if we saw at that point, he still haven't discovered that later discoveries. So he says that this is what I'm saying when that's like the highest level of competence that I am in. But
Mhm.
he keeps developing. He says
Mhm.
I think that what kept Davanloo going is the sense that we can do it more effective. I mean, it can get more effective
Yes.
than we are, and he keeps also like making it more effective. And
Yes.
while with experience, he became like he became more competent and more competent and more competent. And I
Right.
think to saying what Bert is saying is that this determination and keep going to try to make it better. For me, that's what keeps me want to keep learning ICDP. I
Right.
also learned a lot of other models, which I think are good, but there is also the sense that I have it's good, but it can be better.
Mhm.
Is there some way to get it better? And I think that's something in for
Mhm.
me in this model ISTDP helped me think in those. I need
Yeah.
to get a lot of levels
Yeah.
of knowledge of information that comes from the patient and from within me
Yeah.
that can help me like then integrate it in a way that can make me work more effectively. But
Mhm.
it's really hard. It takes really decades to
That's right.
master.
Yeah, Davenant was obsessed with getting more and more efficient, especially time efficient. He really was obsessed, and probably there was a lot of upside to that. There was a lot of good that came out of that. But just very, very briefly to touch on something that I think you alluded to. So we have the case of the German architect, which we read. I think that was one of our first readings, actually. And that was in the late 80s as opposed to the late 70s. And so there he's much more focused on body language and he's focused on size and striated signaling and so on and so forth. So on the one hand, we have that he actually does attend to that quite a lot in that case, and he doesn't go for the sort of pressure cooker exploding with affect type of unlockings. In fact, he refers to an unlocking that is far more humble, to use the words of a colleague, Rachel Goldstein. She called it a humble unlocking, which I agree with. And so there is that in between area in the 80s where he didn't always go for the vertical sort of pressure cooker exploding with affect unlocking, and yet he was still very, very tuned in to having his fingers on the pulse of the unconscious and reading the unconscious. Um, Max.
Oh yeah, thanks for, what Yair was saying and Johannes not focused on the tacticals and the physical, because I'd like to bring the attention to the other paper because there was something that I found really interesting. Um, he talks about the effective function of the ego, and he only talks right now about two forms of anxiety, primary and secondary. So
Yes.
he hasn't come up with striated smooth and CPD yet. And there's actually, I was reading this and it's so interesting because it's so interesting about my work because in a way, what he's referring to Freud as primary is based on past trauma and fear of it's not abandonment, but some
Out of control.
I don't think he uses that word in this primitive form of externally directed separation anxiety. And then there's what he'll come to call striated, what Freud calls signal anxiety, which is a sign that unconscious forces are moving to the surface.
Yes.
And I thought this was really helpful because the truth is the term striated can be confusing. If it's only striated, smooth, and CPD, there's this kind of gray area with anxiety, and I'm seeing in a lot of my work now, where the client is anxious, they're tapping their fingers or their foot, and it's not striated, and that's what I'm seeing is it's anxiety that's not quite striated. And so I don't know if it's primary, what's referred to here as primary,
Uh,
because he talks about it as trembling. And I bring this up because I see a lot of clients where they have anxiety, but it's not quite striated. But I'm working with them or had been working with them in the past as if it is striated, and I'm therefore moving too quickly.
uh,
And I'm hoping I've signed up for this Osmo course where one of the promises is that I'll get to learn how to help get the anxiety into the striated system. But was just interested if anything I'm saying is talking to other people, or if people have any good tips about how to get that slightly. I think the Danish woman calls it tip to toe anxiety. Like
hmm.
the anxiety is a little higher than striated to get it into striated, and that's the question I have, I suppose. If anyone wants to speak to that, or if anyone understands what I'm
Yeah.
talking about.
I think I do, Max.
Yeah.
I think I do. So my 2 cents, and then we'll see what other people think. So, um, primary anxiety is this ripping, usually free-floating anxiety that is just dreadful.
Mm.
And it's usually about like an external event. Something has happened. I'm being assaulted right now. And so you have primary anxiety, or the little
Mm.
infant
Mm.
is left alone in its crib and it has the experience of, I'm dying. There's no one here to take care of me. I can't even lift my head for Christ's sake. So primary experience. If an adult is having that in your office, it tends to suggest that the repressive barrier has been compromised. The integrity of that repressive barrier has been compromised and they're flooded. And so at that point, your job is to actually fortify the repressive barrier and encourage higher order defenses, such as isolation of affect. So that is a very particular kind of anxiety, not to be conflated with like a little bit of fidgeting or something. So the other thing, Max, this may or may not be helpful, but just something to think about, is that there's a difference between striated voluntary muscle tissue containing the anxiety versus a genuine signal, which involves the discharge. That's more of a burp from the unconscious. So if you see a deep sigh, that's a burp from the unconscious. It means that underlying feelings are just below the surface. That's different from just, regular tone, that there's tone and firmness in the musculature. Like, so a little bit of this, assuming it's rhythmic and not chaotic, a little bit of this, it means skeletal tissue is containing the anxiety, but it would be incorrect to interpret that as a proper signal where there's a true discharge. That's more of a burp from the unconscious that tells you feelings are just below the surface. So you want to have those distinct categories delineated in your mind, okay?
Beautiful. Thank you. Very
Oh,
helpful.
sure. Yeah, you bet. Good. Let's see. I think, Anne, are you up? I think it's you.
Yeah, I know, but after what you just said, I'm hesitant to try and say anything. That was really beautiful. Um, uh, May and Rico and Jackie Meltz, they're working on trauma. I
Hmm.
mean, they want us to develop a different way of thinking about trauma. And I have always been absolutely outraged by calling a certain kind of terror that was happened to terrible trauma in infancy to call that anxiety. I mean, anxiety would be a gift. I mean, it's so I was thinking that what I came up with was there needs to be a new nomenclature. There needs to be a differentiation between anxiety, that is a reaction to something collapsing inside, versus real terror from the outside, where somebody's being molested or killed, close to being killed or whatever. It just absolutely, I'm so glad you brought this up. Who was the man who brought that up? Think about anxiety. Was
Max.
that Max? Max, thank you, thank you. Um, uh, I feel I don't know if there's anything we can do to change the nomenclature, because there has to be a differentiation between primary and secondary anxiety.
Totally. Well, in the reading, Davanloo does make that distinction. He's referring to Freud, but it's clear that he understands that difference.
It is. Why didn't
Yeah,
Well,
and
he understands the difference between primary and secondary, but I still, and he does say that it is when the infant is helpless. It usually happens in infants. Primary is usually in infancy, and it's usually when there's real helplessness and there's real danger.
right.
Yeah, but he still calls it anxiety. No, that's not right.
Actually, yeah. Yeah, that's fair enough. That's fair. Sometimes he'll say the word terror. Like I know
Yes, he
you're
did say terror. He
yeah.
did mention that, but then he goes back to anxiety, primary and secondary anxiety. Very confusing.
Right. No, I hear you. It's too minimized to refer.
It
Even the word
minimizing.
anxiety is too minimized. That's point well made, point well taken. Thanks, Anne. Very good. Stephen, and then Bo.
Yeah, I'll try to be brief with this because I feel once again some degree of shame because I think I'm speaking to gods and they already know what it is that I'm about to say anyway. So I'm trying to make this as simple as possible. When you were talking with, I think after Max had said what he had said, something about anxiety, what I have noticed, and I've noticed this in clients in my own practice just of recently or for a while, is that when you get the knee bobbing, where the knee starts to bounce up and down as a person is talking about something, I usually know that's usually after we have brought up a particular subject area in some ways. And I say, I'll point it to them, oh, I notice, are you noticing anything in your body right now? Are you noticing that your knee's going up and down or that they're fidgeting or something, what it may be? And I'm just wondering if you can maybe clarify just a little bit more about that in some ways, Johannes, because I'm thinking that is a form of discharge. It's like if, they're feeling so much what I usually conceptualize it in my own head is that there is a feeling or an emotion that wants to emerge out of the client. And another part of the client says, oh, no, it's not safe to bring that up. You better suppress it. You better push it down. And so there's the tension, almost an isometric is the only way I can describe it. Those isometric exercises where people they push your palm against your palm. It's like you've got one force going in one direction, you've got another force going in another direction. And I'm not sure. You're shaking your head. Are you meaning that I'm on the wrong path here? I'm not sure.
No. It means I'm following.
Okay, right, fair enough. And so something wants to emerge. The client wants to be able to express something, either to state what it is they are feeling or to open their mouth and experience something. But at the same time, too, there is something that is telling them it's not safe or there's some kind of a risk if I dare express what it is that I feel. And so it gets repressed. And then that creates the tension within the body, which then creates the need to be able to discharge, whether through tapping with the fingers or having the knee bob up and down. And every time I say that, okay, there's some kind of anxiety going on, that what the hell were we talking about 2 minutes ago? Right? Because obviously there's some kind of emotional conflict wrapped.
Exactly.
Sorry, there's some emotional conflict that's wrapped up around that somehow, because all of a sudden we weren't talking about 2 minutes ago. Now we are talking about it. And all of a sudden, his knees are bobbing up and down and he's tapping and et cetera, et cetera. And I'm just wondering if you can just explain a little bit more about that, because I don't think I got quite what you were saying to Max just recently.
Well, I don't know. I thought you said it really well just there, Stephen. That's really
I thought I was kind of obscure, to be honest
No, I
with you.
thought that was well put. No, exactly that. So some emotional tripwire gets tripped, right? Feelings get activated, and that mobilizes anxiety insofar as the person has not yet befriended those feelings and worked through that conflict. They get anxious. And if that anxiety is discharged into the skeletal tissue, yeah, you can see voluntary bobbing of the knee. If it's rhythmic, it means the skeletal tissue is still containing the anxiety and discharging it voluntarily, consciously, like that. If it's chaotic, it means they're near a panic attack. It's a difference if the knee is going.
Yeah, absolutely. And so this is also one of the reasons why people say, well, I go out to the gym and you can go on the treadmill as much as you want, Guy, as much as you want. You can be there for like an hour and a half. That's great. But all you're doing is just simply burning out the sugar in your bloodstream so that you don't have the physical energy to allow the tension that you feel within your body to be able to be discharged. But as soon as the blood sugar levels come back up again, you're going to go straight back to bobbing your knee up and down or shifting or twitching or tapping your fingers or whatever it might be as signs of a discharge of anxiety.
It's just going to take the edge off temporarily. It doesn't actually resolve what's driving the anxiety to
right. This is how I kind of can understand it a bit in some ways.
Yes.
And I'm not even sure if I'm saying the right thing here. I hope I'm saying the right thing, but I'm not sure. So
So that just briefly, because I know there's other people that want to speak, but that's what I was referring to. It sometimes it feels like it's discharging too much out of the body, and that's what's making the hands go too much. Like it's not contained enough, and it's discharging out a little too much. It's discharged. That's the term I'm looking for, and the anxiety looks a little too high, and wanting to help contain it more in the body. And I think the intervention you use where you say, I noticed as we're talking about this that your leg started bobbing can be exactly the thing that would help get it back into the
Yeah,
skeletal muscle.
yeah, yeah. Or
Well, I
something.
usually, sorry, Max, is what I usually say about that is I say, hey, I noticed we were talking about, the relationship with your mother, the relationship with your father, the relationship with your brother, or whoever it might be. And just as we were doing that, did you notice that all of a sudden that you started to become agitated, you started shifting in your chair, or, you started shifting around, or your voice sped up as my voice is fast right now, anxiety, or that your knee is bobbing up and down? Are you noticing that? Because you weren't like that 5 minutes ago when we were talking about, your relationship with your boss, for example, say. But now, as we start to talk about your mother, or if we talked about your brother or your uncle, then all of a sudden, this is what happens. Are you noticing that?
Yeah,
And then
look,
maybe you get a sigh.
there you go.
And maybe I get a sigh. I don't know. It just depends. But I'm always on the lookout for like what's happening physiologically with the person in the moment. You know, are they sitting comfortably in the chair with their legs apart, slightly apart? Are they feeling relaxed, or are they sort of on edge and they're feeling physically tense? It looks like they're physically tense, right?
It's great tracking. Just this, the last thing I'll say about it, and then Yair, you have your turn. Again, this distinction between that anxiety is being discharged in the skeletal tissue, but you can have voluntary discharge, like the person knows darn well that they're tapping or whatever, like they know that. It's not the same as a involuntary or a spontaneous discharge, like a sigh. The thing about the involuntary or the spontaneous discharge is that it's a sign that the unconscious is closer to the surface because it's not being mediated through the conscious mind. Yair, go ahead.
Sorry, Johannes, can you say that again? That it's closer to the surface. I missed that point there.
Yeah, it's just two different categories. There's
Yeah.
conscious discharge, like I know I'm tapping my fingers.
Mm-hmm.
It's a spontaneous deep sigh, and they're different animals, not to conflate those two. Because
Mm-hmm.
if you see spontaneous discharge, it's a sign that the feelings are actually closer to the surface because it's not getting filtered through the conscious mediation.
Okay.
So, Yair, you might have the last word here.
I'm thinking during this topic that obviously when we see those signs, it means that I mean, obviously is that the patient has some reaction, and we can think about what is this reaction. We can think about what function does it serve. We can think what does it communicate or what it wants to communicate to the patient. And while you're talking, I'm thinking that one really important aspect that we can also see in the article of the cement man, the case, is that it's really important the way if we a therapist like observe and invite the patient to be curious and say, hey, we see something, we're curious, I wonder what is, do you also notice that? It happened, like you said, Seven, once we started talking about your mother, you have this reaction. I think that what we want to do in the process or in the relationship is to help the patient feel that it's safe to explore what's going on inside of him, and whether that's it's anxiety, it's terror, it's something else. The fact that the patient get an experience that, hey, it's safe, to observe, to stop and observe and be close to what happening inside me, has also like a big effect for some patients, because each time I think that each time we help the patient see some anxiety and he is able to see it, that's another moment where he is also actually um, allowed another person to be really close to him.
Yes.
And this also is a it can be very meaningful for the patient. It's actually can bring, like, for some patients, it can bring more anxiety,
Yes.
realizing, hey, I just let someone get close to me.
That's right. It can also instill confidence. If you are tracking really accurately and astutely, like, did you notice that we just talked about this and now your knee is bouncing? It communicates to the patient, my therapist is paying attention. Not only that, they can actually put words to what's happening in the room. And that in and of itself can render you into someone that they trust. You can win their confidence that way. So that's a great point. With that, we have to stop. Thanks for hanging out, everybody. It was fun. I look forward to
Thank you, everybody.
Thanks.
Yeah,
Thanks so much.
yeah.
Bye bye.
You guys.
See you.